Almost there. All right. So welcome to our second webinar of the series organized by Nobumpnocare in perinatal care. Nobumpnocare is a nonprofit co-founded with Nicole Miglio, my colleague, and I. We strive to provide care, I mean, any kind of care to women and their network during their reproductive journey. We have a wonderful network of philosophical counselors, psychologists, psychotherapists, lawyers, gym instructors, lactation consultants that are there to provide support for women and their network. Today, we are going to host a wonderful presentation from Matthew Cull and his colleagues, Holroyd and Woollard, on the problem of care for everyone, effective and inclusive communication in perinatal care. You can follow this presentation also on my YouTube channel, on Susie Ferrarello, and the floor is all yours. Thank you so much, Matthew, for being here today with us.
Great, thank you so much, Susie. So this is a project that myself, Jules, and Fiona have been working on for some time, where we're thinking about how we might make the language surrounding perinatal care more inclusive, more welcoming, and just sort of nicer to be around for a variety of LGBTQ plus people. Slide. So here's the plan for today's talk. First up, I'm going to introduce the kinds of goals that we might have in the communications surrounding perinatal care. What do we want our communications to kind of achieve? It's sort of nice to be around and then we're going to talk about why a default sex language has been defended by others due to apparent failures in so-called gender-neutral language. And we're going to show that while some uses of gender-neutral and what we will call gender additive language are bad, there are better ways of doing things, and we're going to appeal to a toolbox of additive and neutral locutions, which are going to be able to give us tools to talk about perinatal care in ways which are, on the one hand, sort of ethically amenable, and on the other hand, suit all of our communicative needs. We'll go through some examples to talk through, the kinds of tools that one might use here, and then we'll conclude by arguing for a kind of context sensitivity regarding our perinatal care communications. Okay, so if gendered language is anywhere, it's in the language of pregnancy, right? So when you go into your favorite perinatal care context, there's going to be lots of talks about mums, mummies, and these are the people who are going to be giving birth, and their partner who is the dad, the father, and the dad is definitely not giving birth. Now, clearly, this language, when used to talk about everyone who's going through pregnancy and those around them, is going to be inaccurate, right? So there are plenty of, for example, lesbian couples who are going to involve two mums, right? There are also trans men and non-binary people who are going to be giving birth, and they aren't mums. And so on the one hand, it's going to be inaccurate, but it's also morally troubling. We're going to talk about why that might be the case in a second. However, there have been defenses of this kind of sexed language. So Gribble et al. Have recently produced a kind of defense of a sex language where the meaning of woman is such that everyone who gives birth is a woman. We're going to try and argue against that a little bit here too. So our research takes place primarily in the context of the UK, the United Kingdom, and we're mainly thinking about trans people, but we're also talking about some cis people, some other queer people as well. And if one goes to the data about pregnancy and birth in the UK, over 1% of births are to people whose gender does not match that which they were assigned at birth. So in February of 2022 alone, so that single month, 136 trans people gave birth in England. And as time's gone on, more recent surveys have taken place. That number has only gone up, such that more recent surveys show that there are more trans people than lesbians who are giving birth every year in the UK. And so what we want is language which is going to allow us to make perinatal care contexts welcoming and inclusive to trans people who are very much using these services. We're also concerned with considerations about how the language of perinatal care can exclude lesbians and bi people, and even straight cisgender people who reject particular kinds of ways of thinking about this rich social role of mum, right? So I know one cisgender woman, for example, who really kind of enjoys being a parent and gave birth to a child, but really rejects being referred to as a mum, and it doesn't like the whole what she sees as the cultural context that surrounds that. Now, in the UK at least, and in many other similar sorts of contexts, there's a legal duty to attend to the variety of people who are engaging with a particular kind of care. So according to the National Health Services Constitution, the NHS has a social duty to promote equality through the services it provides, and to pay particular attention to groups or sections of society where improvements in health and life expectancy are not keeping pace with the rest of the population. And in line with the provisions of the UK's Equality Act of 2010, the Constitution of the NHS stipulates that all staff have a duty not to discriminate against patients, and that they should aim to contribute towards providing fair and equitable services for all, and to play your part, wherever possible, in helping to reduce inequalities in experience, access, or outcomes between differing groups or sections of society requiring healthcare. So these provide moral goals for the kinds of things that we, ought to be striving for, not just in our communications, but all throughout perinatal care. But of course, our language that we use in perinatal care contexts is one of the ways in which we can promote the kinds of moral goals that we have here. And indeed, using language poorly can be ways that we fail to meet those moral goals. So in particular, language can be used in an inclusive way, making space for and affirming the entitlement to the care of all users of the NHS, and indeed providers of that care, of course, rather than an exclusionary way. And this matters. So recent reports on the experiences of trans and non-binary people accessing perinatal care indicate that around 28% of trans and non-binary respondents said that they were not treated with dignity and respect during labour and birth. Moreover, interviewees of this report from the LGBT Foundation describe their experiences of exclusion and the harms they experienced as a result. So one said, I felt that there was no framework of language that was inclusive of people who did not identify within the gender, without the gender binary. And so it was a consistently triggering experience. So the thought here is that there's a kind of moral wrong that's going on when we fail to use appropriately inclusive language to care for everybody. And moreover, you might think that this actually is going to put some people off accessing the kind of care that would be really helpful to them, right? So if you've got a care context where a patient is going to be consistently misgendered when they attend it, that patient may well just say, look, screw it, I'm not attending that kind of care. I will try and do a home birth, say, for instance. And that may or may not be an optimal outcome, right? The patient may have been better off and been happier were there a care context, say in a hospital, which was inclusive as well as, being in a hospital. Now, of course, beyond moral goals for our communications, we also have other kinds of goals in designing our communications, which aren't kind of explicitly to do with things like inclusion, respect, sensitivity, and kindness and equality. What are these other goals? Well, for one, we need to care about the reach of our communications. So language should be used to address all those who are apt addressees. So what does that mean? Well, it just means that we're going to have a particular audience in mind when we put out a particular kind of message. And so if we've got the audience in mind, our language should address everyone who in that audience. For example, a message about postnatal care should address all those in the relevant kind of geographical scope, who have recently given birth, right? It would be bad if our message about postnatal care, which, for example, might tell them about some service that people who have just given birth can access, if that kind of didn't reach everyone that we wanted it to reach. Moreover, our language should be clear. It should meet the goal of clarity. Language used should be clearly understood by all of the audiences it aims to reach. For example, it should not use unnecessarily technical terms that may mean that some audiences cannot grasp its meaning, right? If we're putting out a public health statement which uses like really technical medical language, a bunch of our audience who, is just Joe Public aren't going to understand it. And so what we need is language that is sufficiently clear and understandable by the intended audience of our communication. Moreover, our language should be accurate. It should meet this goal of accuracy. It shouldn't express or imply falsehoods. For example, content about birth should not express or indeed imply that only cisgender women give birth, because of course that's not the only people who give birth. Another important goal that we need to meet as well is feasibility. So language should respect the constraints of the format that we kind of have access to, right? So if you've got a leaflet that you're sending out, having 18,000 words that you're trying to cram into this leaflet is not going to work. And this is going to, turn out to matter for some of the more complicated locutions that one might want to use. So we've got these goals of kind of clarity and accuracy and reach, which are sort of non-moral goals. But we've also got these sort of moral goals to do with inclusion and exclusion. And so here I wanted to just get some stuff on the ground about like how one might fail to include a person through one's language. And here we've got, there are more ways of doing this, but here we've got three which we think are kind of really relevant to perinatal care communications. So one kind of way to fail to include people that we might want to include would be an explicit denial of individual identity. And the explicit denial of individual identity ascribes an identity to a person that conflicts with that person's, personal identity. So for instance, you might refer to a parent with a gender neutral identity as mum, or you might refer to a father as mum or a mother as dad, right? And that would fail to include people, in the first case who are gender neutral. It would fail to include the father because you've misgendered him as a mum, and it would fail to include the mother as you've misgendered them as a dad. Okay, so this is kind of explicit, always kind of like picking out an individual and, denying their identity. Another way to fail to include would be a false universal. And so a false universal purports to cover all cases while not including the experiences of some groups. So in our case, the one that we come up against a lot is a false universal that assumes that a given reproductive role is always associated with a particular gender, ignoring the experiences of those of other genders who play the same reproductive role. For example, this is a common sentence that gets used on many breastfeeding information sites. Fathers cannot breastfeed, but can do many other things to support their partner. Well, that's just not true. There are plenty of fathers who can breastfeed. So this is purporting to cover all cases, right? It's saying that, fathers cannot do this. But of course, it fails to, match onto the experiences of those trans men who do breastfeed their children. Finally, incomplete non-universals. This is a way of failing to include, which fails to include by just not mentioning all cases. So a non-universal does not purport to cover all cases. So a non-universal is incomplete with respect to a group if it provides accurate information about some experiences, but does not mention the other experiences. So for example, take the following sentence. Most women can leave hospital in 1 or 2 days after having a cesarean section. Why is this an incomplete non-universal? Well, it's incomplete because it fails to mention those who have cesareans, but who are not cisgender women, right? So there's a group of people who you think might, ought to be referred to in the context of the sentence. Non-binary people who have cesareans, trans men who have cesareans, but they are kind of left out of this. Now, this need not be problematic, right? One might think that if this sentence is combined with an additional sentence saying trans men and non-binary people can leave hospital 1 or 2 days after having a cesarean section, you might think, well, look, this sentence is completely unproblematic. It's just that we've got a separate sentence kind of completing the universal. But it's just something to be aware of. If we just have this incomplete non-universal, we're going to be failing to exclude by sort of omission, as it were. One thing to note here is that what sometimes gets called sexed language won't do here. So using woman or mother to refer to all those who gestate will not meet these moral and linguistic goals. For one, it's going to involve the explicit denial of identities in particular kinds of cases, telling a trans man that they're a mother, for instance. And it's also going to involve false universals, saying that all of those who give birth are women, for instance. Nor will only using sex language, nor will using only sex language such that only mothers, referring to cisgender women, are addressed, be a sufficient kind of way of doing perinatal care communications, precisely because this is a kind of incomplete non-universal. So unless you've got additional communications coming out about and addressing trans pregnancy, it's going to just be incomplete. Such usages fail the moral goals of respect, dignity, sensitivity, kindness, and equality, since these usages respectively misgender and marginalize trans men and genderqueer or other non-binary people who do in fact gestate and give birth. But this kind of use of sex language also fails to meet communicative goals. Messages framed in these terms fail in terms of reach, excluding some people who give birth. They also fail in terms of accuracy and indeed of clarity. So how should one try to include all the people who are going to require access to perinatal care services? In the literature, there are two broad strategies that have been put forward. The first of these is a gender additive strategy, and that's exactly what it sounds like. When you're talking about the people who are, say, pregnant, you just add more genders alongside women. And the other strategy is a gender neutral strategy. And again, this is exactly what it sounds like. You refrain from specifying gender. Okay. But these strategies on their own have been subject to some interesting objections. So this is from a paper from Gribble et al. They have 6 kind of objections to gender-inclusive language. Their first objection is this, that gender-inclusive strategies may violate the plain language principle of health communication, whereby members of vulnerable groups may be excluded by language that they struggle to understand. So remember that one of our goals was clarity, and that sometimes gender-inclusive language might involve technical terms, which means that people who we want to reach through our communications might not be reached. Gribble et al. Also claimed that gender-inclusive language is dehumanizing. So they write that some language marginalizes women, right? So if you're talking about non-males as people who could give birth, you might worry that this kind of marginalizes women's experience or treats it as kind of, other to men and men as kind of the kind of primary existence. You might also worry that it sort of dehumanizes in kind of undermining women's humanity by using terms like gestational carrier or the gestator or indeed the menstruator. This language is kind of weird and kind of almost like reducing people to a particular kind of bodily function, you might think. The third objection is that this kind of gender-inclusive language can lead to wrongful inclusion. So phrases such as pregnant families or breastfeeding parents might include partners who are not pregnant or other family members, and thereby infringe on the autonomy of the person gestating, giving birth, or lactating, by implying that these others have rights regarding decisions that that should be made unimpeded by the person who is in fact pregnant. We'll come back to that objection in a little bit because it's a really interesting argument. Fourth, Gribble et al. Argue that it leads to inaccuracy, imprecision, and confusion. This is due to the careless replacement of sex terms, and this can lead to inaccurate or misleading representations of research in health communication, where, for example, the comparison class is misdescribed or badly chosen. Again, we'll come back to this in more detail. They also worry that it might be disembodying, that the failure to use terms such as breastfeeding can detach those doing it from the process and erase the person who's doing the feeding. And finally, they worry that gender-inclusive language sort of imposes a Western worldview onto people who might not hold that worldview. So it's a kind of cultural imperialism. Now, we think that some of these objections are better than others. We want to sort of kind of dismissed the dehumanization and disembodiment worries quite quickly by saying, look, dehumanization and disembodiment only arise with some variations and versions of inclusive language, right? So we agree with Gribble et al. That the words gestational carrier or the gestator or the menstruator, that kind of reduces persons to their functions as gestators. Seeing people who are giving birth as, disembodied uteruses, something that we should be worried about in a variety of contexts. And I've already described the worry about, the defining people in terms of the male, right? So the objection to non-males as well. We agree that these terms are indeed dehumanizing, and so are cases of unsuccessful attempts at inclusive language. Describing people as gestators runs the risk of objectifying them in several senses, including by reducing them to their body, dying their subjectivity, and instrumentalizing them as reproductive baby factories. But of course, it's not obvious that we need to use the term gestators or indeed the term non-males when we are using gender-inclusive language. And as we'll see, there are plenty of other locutions which are quite the opposite from dehumanizing and disembodying, but rather a person-first language. We also think that the worry about cultural imperialism is misplaced as well. Insofar as this worry sees inclusiveness of genders beyond the binary as a Western construct, it misrepresents the history of colonialism, trans and non-binary families, and gender-diverse people in non-Western contexts. Indeed, part of many colonial projects was precisely the attempt to impose a rigid sex and gender binary on the native other and to exclude the possibility of life beyond the binary, often with violent force. So gender exclusion rather than inclusion was, of course, the mark of Western colonial project. However, even if this worry were correct, the proposals that we will put forward in this presentation do not insist that anyone use a particular label to refer to themselves or others. And we might remark that this is marked contrast to those who would impose the label women on anyone with a uterus, for example. However, we think that Gribble et al. Do have some concerns worth taking really quite seriously. That is, number one, the reduction of overall inclusivity through the use of bad gender-inclusive language. The worry three, that we could wrongfully include people who ought not to be included. And four, the worry that inclusive language, when done badly at least, leads to inaccuracy, imprecision, and confusion. And we'll use examples in the rest of this presentation to explore how to respond to these concerns, showing that sex language in Gribble et al.'s sense of sex language should not be treated as the neutral default option. Just a point of clarification here, when we talk about sex language here, we're not objecting to the use of terms that talk about, say, vaginas or sexual characteristics. We're talking about the use of the term woman as defined in terms of a particular kind of set of sexual characteristics. So it's perfectly compatible with this sort of approach that you use language like people with prostates, but using the term man to equate it with all those with prostates was the kind of thing we object to. So we also want to say that the gender additive or gender neutral approaches each alone cannot be adequate. Instead, we endorse a pluralistic approach, exploring a range or toolbox of options that, when exploited well, establish great ways of doing inclusive language and use tactics like alternatives to noun and pronoun phrases to find appropriately inclusive. Okay. So let's take the following case of somebody trying to translate a gendered piece of language into sort of gender neutral language, and how it can kind of go wrong. So this is sentence 2 here. Pregnant women, who are the target class here, those pregnant women with COVID-19 have higher risk of certain complications compared to non-pregnant women, the comparison class that we're in for here, with COVID-19 of the same age, right? So we're trying to compare those women who are pregnant with non-pregnant women and compare their rates of COVID-19. And you might think, well, look, here's an easy way to make this gender neutral. Pregnant people with COVID-19 have a higher risk of certain complications compared to non-pregnant people with COVID-19 of the same age. Okay. But it's not clear that this is a legitimate move. Without further context, it's not clear whether the move from describing the target class in 2 as pregnant women to, in 2b, pregnant people is legitimate. was the research that this statement based on, defining a woman in the target class in its research, in the research that was actually done, in a way which kind of grouped in non-binary people and trans men who are pregnant into the class women, or was it a piece of research which excluded from that class? So in order to kind of get the second sentence right, we'd need to know whether the data described into pertain to all pregnant people, misdescribed as pregnant women, or not, right? And in each case, we're going to have a different sentence being the one which most improves accuracy and inclusion. Moreover, and this is referring to the same two sentences here, if the data pertains only to pregnant cisgender women, the move to a gender-neutral framing distorts the meaning and produces inaccuracy. The use of pregnant women in 2 is either an exclusionary erasure or an under-described imprecision that fails to indicate the true scope of the data. Nor is it clear whether the comparison class in 2 refers to all non-pregnant women, cis and trans, or rather refers to only cis women or cis women and those assigned female at birth who do not now identify as women. And without that clarity, the ways in which 2b distorts the meaning is unclear, though clearly it does so in at least one way. On no reading is it reasonable to assume that cisgender men are intended to be a part of the comparison class. But of course, 2b includes them as part of the comparison class because they are captured by non-pregnant people. So my colleague Jules went and looked at the studies that this statement was based on, and even upon closer examination of these studies, it was not entirely clear whether the most accurate rendering of the information that these studies kind of ought to suggest is correct was 2c, those who contract COVID-19 while pregnant have a higher risk of certain complications compared to a sample of non-pregnant cisgender women of the same age who contract COVID-19. Or it was meant to be those who contract COVID-19 whilst pregnant have a higher risk of certain complications compared to a sample of non-pregnant adults assigned female at birth who contract COVID-19. What I want to kind of conclude from this example is that the goals of inclusion, clarity, and accuracy cannot be secured simply by replacing woman with a gender-neutral term, as in 2b. But, contra Gribble et al., nor are those goals served well simply by using the default terminology of woman, which either is exclusionary or imprecise, right? However, we worked out exactly what the meaning of 2 was. It was going to be one of the 2. So attention is needed to the details of the semantic content, the meaning of the particular terms as the research was done, and more precision than is needed than is present in either 2 or 2b. And more respect and inclusion is needed than is secured by the default exclusionary use. Another example that we might consider is the following. So Gribble et al. Worry that in some contexts, replacing the term woman with person with a cervix may mean that some of the intended addressees of a message are not reached by that communication. So they worry about, this is a non-perinatal case, but I think one which is helpful to explain the idea. All women with a cervix between the ages of 25 and 64 should go for regular cervical screening. So here's a way to kind of make that gender inclusive. All people with a cervix between the ages of 25 and 64 should go for regular cervical screening. Now, Gribble's objection is that the message of 3a may not be clear to some people who are unaware that they have a cervix. Some people may just not know what cervixes are. Others may know what cervixes are, but be unsure of whether they themselves have them, right? And this is a big picture, problem for sex education in general. But in the imperfect world in which we live, we've got to do perinatal care communications to reach people, who may have imperfect knowledge about biology in general and indeed their own biology. Now, Gribble et al. Take this to support the thought that retaining sexed language, whereby women refers to all those people with a cervix, has some merit. However, we don't think this is right. First, of course, some trans men or non-binary people may be unaware that the description person with a cervix applies to them as well. So language is needed that makes clear that they are potential addressees of the message. And using woman to apply to all those with a cervix does not do that, right? They're going to be unclear whether they are welcome to access these cervical screening exams because the sentence explicitly excludes them. It says all women between the ages of 25 and 64 should go for this kind of cervical screening. Well, as a trans man or a non-binary people, should you go for that? Moreover, there are other linguistic strategies available to us other than using the sex to default, though identifying the adequate one requires careful attention. So here's how you might work through some examples of better ways of doing it. So here's an alternative. 3B, all women and people with a cervix between the ages of 25 and 64 should go for regular cervical screening. And an even more precise message regarding its addressees would be something like the following. All women and people with a cervix, which can include trans men, genderqueer and other non-binary people, between the ages of 25 and 64 should go for regular cervical screening. Now, these formulations are consistent with the gender additive approach, which has been prescribed by the likes of Green and Riddington, but they are unsatisfactory. Note that in 3B and 3C, scope issues arise. So is R3 and 3C addressed to all women and all people with a cervix, or all women with a cervix and all people with a cervix? Now, if it's the first of these options, if it's option 1, there's a problem of overreach, since not all women have cervixes. There are plenty of cisgender women, and indeed most transgender women don't have cervixes. But we'd be inviting them along to, or telling them to get regular cervical screenings, even though they don't have cervix. If the proper reading of 3B and 3C is that it's addressed to all women with a cervix and all people with a cervix, there's a really problematic implicature here. Since this message implies that women are not included in the group of people with cervixes. That implies that those women with cervixes are not people. So we get a kind of message of dehumanization here. So thus construed, concerns about implied dehumanization of women arise once again. Thankfully, though, 3B and 3C aren't the only options we might go for. These problems could be resolved with the following reformulations. So 3D, all women, trans men, genderqueer and other non-binary people who have a cervix and are between the ages of 25 and 64 should go for regular cervical screening. That's option 1. And this is kind of an explicit additive approach. 3E kind of combines some gender-neutral language with some additive language. Everyone with a cervix, brackets, which can include women, trans men, genderqueer, and other non-binary people between the ages of 25 and 64 should go for regular cervical screening. And moreover, we can also add on other sentences which might, prompt people who are unsure whether they've got a cervix to go to speak to their medical practitioner. So we might add on the sentence, consult with your care provider if you're unsure whether this applies to you, or something along those. Now, importantly, neither 3D or 3E imply that women are not persons. So we solved that problem, which was a sticking point with the previous ones. They also have the virtue of implying that some people with cervixes are not considered the default or typical case, with others, particularly trans men, genderqueer, and other non-binary people, being considered sort of marginal, right? So you might think, look, 3B sort of says, look, all women who are kind of like the primary people with cervixes and the other lot who are the other people with cervixes, it sort of marginalizes the others slightly. So gender additive approaches themselves admit of different variations, and attention is needed to the reach, implications, and inclusivity of these different formulations. And this is the message that I want people to take away from this, is that if you want to do inclusive language, which you should want to do, you've got to think through carefully about how you do it. Doing it uncarefully can lead to unfortunate implications and failures of reach and failures to accurately describe the people that you want to access the particular kind of care that you want to bring them into. Moreover, while some form of gender additive language might be the most appropriate strategy for single sources of information, other sources of information might be more targeted. So another option that may serve the goals of reach, clarity, accuracy, feasibility, and inclusion will be to have multiple messages, each with incomplete non-universal statements for different audiences. So we might imagine a medical center for GP services, general practitioner services. You might have like a little stand with a bunch of pamphlets on it, which provides information. And in that context, you might have more targeted messages that are more feasible. So one little leaflet for cisgender women, another pamphlets for trans people who are pregnant, and so on and so forth. So it need not be problematic to have some messages addressed to women with a cervix, and other messages addressed to anyone who has a cervix or trans men with a cervix or so on and so forth, so long as both are visible to the audience to whom they're intended. The reach, accuracy, and inclusiveness of the non-universal messages should be evaluated in their totality in these instances rather than in isolation, right? So we've got to think carefully about how are we going to do this such that it doesn't unintentionally exclude this or that group, right? We can imagine one group of leaflets running out first or something, and it might be trouble. Okay, so let's turn to a perinatal case to kind of work through another set of problems. Consider the following message. All pregnant women in England are offered a blood test to find out if they carry a gene for thalassemia. Now, a purely gender-neutral alternative would be something like the following. All pregnant people in England are offered a blood test to find out if they carry a gene for thalassemia. Now, it's unclear whether the same concerns that Gribble et al. Have about understanding information about the cervical screening would arise in this case. Namely, that the use of gender-neutral language may obscure understanding about whether the claim applies to oneself because of a lack of knowledge about one's own body or medical terminology. Now, obviously, sometimes people are unaware about being pregnant, but it's less clear that this unawareness would be remedied by language that addresses members of one gender kind pronoun. Moreover, that kind of gender-neutral option seems preferable to gender-additive formulations such as the following. All pregnant women and pregnant people in England are offered a blood test to find out if they carry a gene for thalassemia. And all pregnant women and pregnant people, which can include trans men along with genderqueer and other non-binary people in England, are offered a blood test to find out if they carry a gene for thalassemia. Of course, these additive messages raise similar worries about dehumanization to those that arose for 3C in the previous example. The implication there being, look, maybe women aren't people, because it's saying all women and all pregnant people, all pregnant women and all pregnant people. It seems like it's implying that they're separate categories. Moreover, like 3C, 4C has a marginalizing effect and suggests that the focus is on cisgender women who are pregnant, with other pregnant people treated as marginal. But you might say, well, look, I do want to stick with the additive option for this or that reason. Is there a workable gender additive option in this case? Well, one of the ones that we thought might be a little bit better would be something like the following. 4D, all women, trans men, genderqueer, and non-binary people who are pregnant in England are offered a blood test to find out if they carry a gene for thalassemia. Now, the gender-neutral option, 4A, remember that was all pregnant people. And the gender additive option here, 4D, have the same semantic content and reach, right? They pick out the same group of people and also seem on a path of clarity and accuracy. One concern that may favor the additive over neutral expression is the often expressed concern that neutral language renders women invisible. And you might think that this is problematic insofar as women and women's work in pregnancy and childbirth has been unrecognized. However, it should be quite clear that women are not rendered invisible by the additive statement in 4D. After all, it explicitly calls out women. Nor, of course, are other people who undertake the labor of pregnancy and childbirth rendered invisible, right? So you can run a similar sort of worry that like gender neutral language might, render invisible the reproductive labor done by gender queer people who are pregnant, for instance. So an additive kind of like set of an additive locution is going to allow us to kind of sidestep these worries about invisibility by explicitly calling out the groups who are affected or relevant to the case. One thing that might favor the neutral option, however, is it's a lot shorter, right? So if you're limited for space, you might say, well, look, I've only got 140 characters in this blue sky skeet or whatever, so I'm going to just stick to the gender neutral option because it's kind of it's a lot shorter. Whereas the locution, all women, trans men, genderqueer, and non-binary people, that's kind of big and unwieldy. So there are reasons that if you've got kind of issues of kind of like space, or you have kind of like a limited ability to kind of say everything you want to say, maybe the gender neutral option is the better one. And of course, there's nothing to stop you from using these in combination. For instance, using an additive approach at the top of your leaflet, followed by a neutral approach later on in the leaflet. And there, of course, is there are plenty of other options beyond merely additive and neutral language. So in this case, we might think there's the additional option of the second person. What's the second person? Well, we're addressing those who are pregnant directly. We can use the second person and avoid the gender kinds or noun phrases entirely. So you might say, if you're pregnant, you'll be offered a blood test to find out if you carry the gene for thalassemia. And this also has a particular kind of affect to it, which is quite nice, I think. So it has a more sort of like a bedside manner to it, which you might appreciate. If you're pregnant, rather than those who are, pregnant, right? It's going to perhaps be a little bit more welcoming for a patient, for instance. Moreover, we might use the first person plural as well. This is going to be in really specific cases, but you might say, if we're pregnant, referring to all of those people who can get pregnant in a sort of maternity group context or other such contexts, you might think that the first person plural, words like we, might be a way of getting another kind of option. Maximizing the overall inclusion of our language is best done by the careful use of neutral or additive language, second personal language, first person plural language, or multiple targeted messages with careful attention to the reach, accuracy, and clarity of each method. There's further worries, though, which I think we ought to address, and this is a really kind of interesting case. So the further worry is this: look, moves to inclusive language might result in including too many people, and doing so in a way that overlooks the particular kinds of care undertaken or the particular vulnerabilities faced by those who give birth. So consider the following example. A woman's experience of childbirth can also improve with a labor companion of their choice, right? What we're trying to do in this kind of communication is say, look, if you're giving birth, maybe think about asking for a labor companion, or here's a supply of labor companions who could help you out, right? Something along those lines. Now, in its current form, 5 obviously fails in reach and inclusion, since it fails to address those who give birth who are not women, or does so whilst misgendering. But substituting some gender-neutral language could be problematic. So take the following. A birthing family's experience of childbirth can also improve with a labor companion of their choice. And whilst this is more inclusive in some respects, 5A changes the meaning of the sentence, now failing out to pick out the specific person who gives birth, right? So we might think that the person who is giving birth should be the one to decide on whether or not to have a labor companion. But this gender-neutral location, accidentally allows the decision-making to be, shared out amongst the family, which perhaps the birthing person wants in that case, but we don't want that to be the general rule. One thing I will say is if you start thinking about this, this problem also arises for 5 as well, right? So imagine a lesbian couple. You got 2 women, one of whom is giving birth. A woman's experience of childbirth can also improve with a labor companion of choice, right? We're not picking out the person who's giving birth here. We're just saying that a woman who happens to be in the room. I mean, we're not even saying they're in the room. They, if we've got a woman who's the midwife, are we saying that their experience of childbirth can also improve with a labor companion of their choice? The intention of this sentence was to try and say, if you're the person who's giving birth, you should have, you have access to a labor companion of your choice. And both 5 and 5A fail to kind of capture that. Here's a better gender-neutral option. And this would be a substitution that picks out the birthing person, at least hopefully. I don't know why we decided to change the numeration here, but this is 5A star star. The person giving birth's experience of childbirth can also improve with a labor companion of their choice. So this is saying, look, the person who's giving birth, their experience of childbirth can also improve with the labor companion of their choice. We're trying to pick out that particular person. So crucially, some uses of gender-neutral language will include some people that it ought not, but some gender-neutral language can avoid this concern, as with 5A star star. We can also do gender additive options, and we can have bad or good versions of these as well. So consider the following. Women and pregnant people's experiences of childbirth can also improve with a labor companion of their choice. Or women and pregnant people's, including trans men, genderqueer, and other non-binary people, their experience of childbirth can also improve with a labor companion of their choice. As earlier, issues arise regarding scope, ambiguity, and overreach. The target is not all women, since not all women, cis and trans, give birth. What is implied? Women are not people. and the marginal status of those who are not women, those who get relegated to the parentheses. But of course, both of these locutions also fail to pick out the particular person who's giving birth. And that was what we wanted our particular sentence to go for at the start. So a better adjective option might be something like the following. The experiences of women, trans men, genderqueer, and other non-binary people who give birth can also improve with a labour companion of their choice. Right? So here we're trying to pick out the person who's giving birth and say, it's their experience that matters. They get to kind of like choose to have a labour companion or not. It's also worth considering how these issues arise in relation to inclusive language around infant feeding, since this is a particularly challenging linguistic context, and particularly politically salient in many contexts as well. Infant feeding decisions are often emotionally fraught, with many parents reporting that significant negative experiences, including guilt, shame, lack of support, judgment or pressure from others, and feeling that required to justify their decisions, however they intended to feed their baby. Infant feeding is also a site at which exclusion and discrimination occurs for trans and non-binary people who have given birth. For example, the LGBT Foundation reports that the terminology of breastfeeding often induces dysphoria or discomfort for trans or non-binary parents. Their survey respondents reported a lack of information about feeding their babies, and less than half of the trans and non-binary respondents felt that their decisions around feeding their baby were always respected by midwives. So let's consider a case. So consider the example of language in the context of advice on how to get the hang of breastfeeding. We took this from a website which is like advice on how to get the hang of breastfeeding. And we came across this sentence, getting the hang of breastfeeding happens faster for some women than others, but nearly all women produce enough milk for their baby. Now, this kind of language is perhaps problematic in terms of inclusivity and clarity, with exclusive reference to both women and breastfeeding rather than breastfeeding or chest feeding, or expressing your milk or something along those lines. And you might think that there are some better options here, perhaps. Getting the hang of feeding can take longer for some than others, but nearly all people who have given birth produce enough milk for their baby. And this is a purely gender-neutral option, and given the discussion above, the most defensible gender additive option would be something like 6D. Getting the hang of feeding can take longer for some than others, but nearly all women, trans men, genderqueer, and other non-binary people who have given birth produce enough milk for their baby. However, in this particular context, the analogues of gender-neutral and gender additive language that were good options in the context of other examples above are problematic. Why is that? Well, it's just that we don't know whether they're true or not. There is not yet extensive data about what trans men who have had, say, top surgery can expect when it comes to lactation, because there are considerable data gaps about breast or chest feeding for trans parents who've given birth. And these issues are not unique to trans men and non-binary people. There are, of course, other groups who may face specific obstacles to feeding an infant via lactation. Those who have had mastectomies for other reasons, such as cancer treatment, and those with Poland syndrome may also experience difficulties. The messages above marginalize those who cannot produce sufficient milk. Now, on the one hand, we've got this goal that we want to not marginalize those who aren't going to produce enough milk or may not produce enough milk. On the other hand, what this message was intended to do was reassure parents, right? It was intended to reassure those people who are trying to breastfeed their child that they will be doing it good enough, right? The statement that nearly all women produce enough milk to feed their baby, well, it's intended to reassure parents that milk insufficiency is rare. And of course, many people who would like to continue feeding their baby with their milk stop because of such concerns. It may seem as if we have here a conflict between this goal of reassurance and the goal of inclusivity. However, we think that this conflict may merely be apparent. A more specific statement can identify groups which are more likely to require extra support with feeding. And this can be reassuring for those who do not fall into those groups and helpful to those who do. However, this has now gone beyond issues of language. To do this properly, we need to do more than simply change the way we talk or write. More content is needed. We need to know which groups need additional support. And for that, we need to go beyond just like doing communication well. We need to go out and do some research to figure out like exactly what the situation is for a variety of people lactating in this way and what can be done to support them. So a better option might be something like the following. In the meantime, whilst we don't have that research, getting the hang of feeding may take a little time, but most people who have given birth produce enough milk for their babies. Some people do require additional support with infant feeding. If you think that this applies to you, do ensure that this is discussed with your care providers. Now, this version highlights the importance of being aware of the different ways particular sentences can fail to be inclusive, as discussed in section 2. The first part of 6E is an incomplete non-universal. But unlike a false universal, it does not purport to cover all experiences. It refers to most people. However, it is incomplete and potentially marginalizing because it leaves out these other experiences. And of course, what we do in the second half of the statement is to kind of complete that universal. The first half of the statement is potentially marginalizing to those who cannot produce sufficient milk or have other concerns about infant feeding and lactation. But this effect is counteracted when it's accompanied by the second statement, which explicitly acknowledges their needs, and at least, in this very vague way, because we're just doing an abstract example here, tries to point them towards resources to help, right? Go to discuss this with your care providers. If you are doing this in a particular care context, you might say, go and talk to this particular person, right? Might be an option on that communication. So our conclusion that we sort of want to push here is something like the following. We've seen that it's essential to ensure that the language that we've used around perinatal care is inclusive in order to meet the moral goals of dignity, respect, and equality, and communicative goals such as reach and accuracy. But it is a task that requires careful thought, because well-intentioned but badly executed attempts at inclusive language can fail to meet those moral and communicative goals and can sometimes make things worse. We think that a pluralistic approach involving additive language, neutral language, second personal language, multiple communications, first person plural language may be appropriate in different kinds of contexts. No one strategy will meet all of the moral and communicative goals that we have across all contexts. So what we've got to do is be careful in considering the appropriate strategy for the particular context in which we're putting out this or that communication. Thank you very much for listening.
Thank you so much for this beautiful and necessary presentation. It's it was absolutely necessary. I open now the floor to questions. I started with a small remark. Well, actually, it's an invitation more than a remark. I already spoke with Nicole. If you would like to help us to rewrite, to reread our page, our front page in a way that can be more inclusive, because I personally struggle with language when I have to communicate something that is like now. The presentation of a seminar, and I realized that there's a limit in the language, and I struggle in how to make to be precise and natural at the same time, presenting something that flows, that can arrive to everyone. And I think that what you're doing is absolutely essential, because we need to be inclusive. But sometimes we don't have the tools, so we don't have the education. Maybe there's the intention, but not enough tools necessary to fulfill that intention. So, yeah, I drop on the table this invitation for you to join on our network to help us to be as inclusive as possible.
Yeah, totally. And if you send the kinds of things you'd like us to look at,
thank you.
Myself, Fiona, and Jules look at things, and we can
Fantastic.
try and help out if we so it's not a problem yet. Send anything you want to discuss.
Wonderful. Thank you so much.
And yeah, I mean, like myself, Jules, and Fiona are 3 professional philosophers of language, and we're all native English speakers, right? Mm-hmm. And some of us are members of the queer community, and so we're about as expert as you can come on this stuff. And it took us working through all of these examples to get things right. So we're not saying this is easy. We're saying this can be quite challenging, and we're just trying to provide people with tools to make things slightly easier. Saying, look, here's a variety of options that you might go for. And of course, it doesn't help that a lot of the language around, especially trans identities, is evolving all the time. Such that, like, even if you think I've got things right, as time moves on and language develops, language that was appropriate to talk about the gay community 30 years ago might not be appropriate in 2025, right? Like things are constantly shifting. So it's a case of just trying your best with the tools that you have available. And oftentimes people will recognize, especially in care contexts, that you've tried to make it trans inclusive. And so they'll say, oh, these people are trying to welcome me, even if they got something wrong. Like the intent, if you make the intent clear, right? Like that's often what matters in case of trying to get a trans person to come to your postnatal care clinic or whatever, right? Like making sure that the person knows that they're going to be welcomed in this space, even if this kind of pedantic worrying about language is something that us philosophers of language really go in for. But oftentimes, trying to do it right and making clear that you're willing to kind of update things and be responsive to feedback from these people, is an important way of like getting the kinds of inclusive effects that you want anyway. So you don't always have to be perfect.
Thanks. That's a good point. A curiosity: do you work? Are you engaged with? I don't know, hospitals, structures that are because that would be ideal to work side by side with people that have this good intention and want to put it in practice.
Yeah, we do these sort of workshops once every 3-4 months or something, and we invite people from NHS trusts, the smaller bits of the NHS, nurses or medical professionals of all sorts, really, but it's mostly like cool nurses who show up and they come along and they we work through some of these examples, and we try and get them to bring examples of stuff that they have in their in their sort of like in their day-to-day work that they want to kind of work through and figure out like the best way to put things. And we try and as a group we all get together and go, this might work, that might work, that might be the best way to put things. And yeah, so we do these sorts of day-long workshops online. It's all free and stuff, so we're not like trying to grift anyone. So yeah.
Nicole, I saw she has a question.
Yeah, actually. Thank you so much. It was super interesting. And wow, I really don't want to be in your shoes. It's super complicated. And my background is in phenomenology. And I actually wrote a book for Bloomsbury when I use the expression gestational self or gestating self. And I really see the objection you mentioned about, not over reducing the whole identity of person to a given task, let's say. But on the other side, it was like the only possibility I really got to try to be as inclusive as possible. And also, that's something that is really important to me. So I just wanted also to bring that on the table, that there is a very curious and problematic overlapping in our languages, and I'm talking about English, but also in Italian, for instance, between parental roles and gender roles.
Yeah.
So when you mention I use also gestational self for being very crystal clear that pregnancy is not motherhood. That's something that I'm like a huge theoretical point. And it's so problematic that, we assume that everyone gestating is going to be a mother or feel herself themselves as mothering, because, being a mother, and stand with Sarah Rudick is like mothering. It's not a full whole identity. So given that, considering this side of the language, do you think that also the social and cultural presuppositions about this overlapping between parental roles and gender roles is on the way, and so it complicates further or the framework? Thank you so much.
Yes, it's what I want to say to that. Yes, it's and this is something that Fiona especially works with. If she were here today, she'd go off on this question. But she's especially interested in the question of whether we should abolish motherhood, right? Not in the sense of getting rid of, the activity of having kids, but in the sense that you're talking about this rich social role. And she was saying, no, we want, there are good bits to motherhood. We want to hold on to it, but like take this notion seriously, that like there's a bunch of problematic, like patriarchal assumptions built into our cultural understanding of motherhood, which are like patriarchal bullshit, right? And ought to be rejected, right? So like there's this kind of tension that we want to, on the one hand, right, not everyone's a feminist academic with a critical perspective on motherhood, right? And on the other, and that's often who we're trying to reach for these perinatal care communications. On the other hand, we want to like also be able to say, well, look, we're still feminists who are critical of patriarchal roles, and so like how to do that best is a difficult question. I don't really know how to answer it. I really want to read this book. This sounds great, and I'm actually kind of like, personally, I think gestator sounds really cool, and like if I could, I would kind of adopt it as my sort of like identity where I do this. And yeah, so like I'm on your side, but also I think it's got to be something that like comes from the individual, that they want to adopt the term gestator rather than us kind of like putting it on people, which I didn't think you'd be saying anything like, but yeah.
Yeah, totally. Yeah. Also, I mean, I don't know how it goes in the UK, but in Italy, when you go to obstetrics or midwives for your first ultrasound, like 8 weeks, 9 weeks of gestation, clinical practitioner says something like, okay, the father stays here and the mother, and you're like, guys, just got a missed period. Hold on. Calm down. So I was wondering if you got this kind of absence actually of guidelines also in the UK. I don't think so. I think that your guys are like not in medieval age, but it's something that you encounter when talking with National Health Service.
Yeah, so it depends. I mean, there is inclusive language guidance that the NHS has. However, de facto, rather than in the law is one thing, and how things play out is another thing, right? And so it often how things get played out depends on like whether your nurse is who's doing the ultrasound is someone who like is aware that a lesbian couple might be coming in, rather than so even though that the NHS does have some good, or at least it used to, things are in flux in the UK at the moment. You may have come across this, but they used to have some reasonable guidelines, and many kind of like medical practitioners sort of they'd learnt about this at some point, but they hadn't thought about it in years. And so as how things got actually played out in practice, sometimes it did end up like the kind of story you were telling. Although there are, as I said, there are plenty of wonderful medical practitioners here in the UK who are trying to like be as inclusive as possible as well, right? Like especially the people that come to our workshops, they're already kind of on board with it, and they want to make things better. Right? Yeah. I will say, because you mentioned Italian, our toolbox here is, we think it's like applicable to other languages, but we don't know other languages. There are some other philosophers who are working on inclusive language in Romance languages. Martina Rozzola at Milan, I think, is working on Italian.
Martina, she's now in Barcelona. Yeah, that's a friend.
Oh yes, of course, yeah.
I mentioned you, Susie. We're close friends. Yeah.
Oh, wonderful! Yeah, no, Martina visited the place where I was doing my PhD for a while. I love her so much. Yeah, she's wonderful. But yeah, she's doing some really cool work along with Isela Gonzalez Vasquez and oh goodness me, Anna Kleiber, on various European languages, and trying to think about how you might do more inclusive language. But I think that the job in Europe is way harder than the job we have in Europe. I've internalized Brexit ideology. The job in Europe is much harder than the job in the UK, precisely because English as a language is way less gendered. Like we don't have genders. We've got gendered language, but we don't have like gendered. What's the particular term for it? Gendered modes for our Italian does. So their job is a lot harder, I think.
Thanks a lot.
Yeah, I had a question, but I don't know how to raise my hand on Zoom still. I couldn't find it. Thank you for your presentation. It was really nice. And throughout the presentation, I was also thinking of the notion of motherhood and mothers. Nice that you brought it up. And I think the context of your presentation and the sentences you analyzed were more healthcare and academic text oriented, I think. So it was a more informal, formal and impersonal use of language. And I was thinking, so like, of course, when we think of a more cultural, social context of language, I think the word mother or words like this are not easily translated, because we have, for example, Mother's Day, or like when I think of my mother, I think of like motherhood as this like really big and like pluralistic semantic bubble, for example, which wouldn't really be replaced by person who gave birth to me, or a person who did this to me, or person this and that. And of course, there are a lot of really bad ideas planted into motherhood and womanhood and femininity, but I think also it's a very rich term in a sense, or it also connotes a really rich familial bond. Like I grew up with a lot of women around me. It was like my grandma, aunt, mom, like all, we lived really close. And my grandma's friends, they would come over a lot, and I didn't see them as mothers, but they were also really comforting, like maternal figures in a sense. And I think these culturally rich aspects of words, when we try to make it more inclusive, fail if we just use this more academic approach in real life. So I wanted to ask how you would translate the scope of your research into something more daily and personal.
Yeah, good. Yeah, we focus on the sort of like more like professional and sometimes academic stuff, precisely because, well, on the one hand, it's easy to access that sort of language. Like we can take quotes from websites and go, hey, you use this and here's how to improve it. But also because it's sort of the people who we're trying to engage with are, you know, medical professionals working for these, the NHS, for instance, right? So totally, yeah, this isn't focused on these sort of more interpersonal and sort of more richly cultural situations. One thing to like absolutely hold like clear is that we're not advocating for the getting rid of the concept of mother, right, or getting rid of the concept of dad or whatever. It is that in these contexts where we're trying to like get everyone who needs this kind of care, using just that language or just that language without other stuff is going to fail. And so like we do want to hold on to these concepts of mother and father, because there are going to be contexts where that language is the most apt language to use. And precisely in the kind of context that you're talking about, like figuring out like, you know, our family relationship where I've got a mum, but I've also got all these maternal figures in my life who aren't mums, but they're mums, you know, and that sort of stuff is like a really important part of like our like social lives, right? And so like figuring out how to do that, I think comes a bit apart from like the demands of a public health service, right? What was the other thing I wanted to say? I wanted to say something else, which was oh gosh, what was it? Yeah, it was a really rich question, and there was another part to it that I've forgotten. Oh yes, the thought that like what to do on a sort of like more small scale, like interpersonal like situation. There, it may be absolutely the best language to use would be these very rich, sometimes problematically patriarchal kind of like language, right? If someone comes in and is like, I'm the gruffest dad and my partner is the mumliest mum, and you know they do like hyper patriarchy or whatever, right? And they want to be referred to in that way. Like the best thing to do generally when like interacting with patients who are like that is probably just to go with what they're talking, how they're talking about themselves, right? And similarly for trans patients as well. Like you're trying to individually respect that their identities in just the same way as here, right? The place to like undermine the patriarchy is not when these people are going through one of the most stressful like times of their lives, one might think, right? So like on like a more sort of like bedside manner stuff, like just following the person who you're talking to is the way to go, rather than like trying to like talk in this quite abstract way that like the sentences that we go through in the presentation are quite like abstract, like if you're putting out a pamphlet, you know, which is like, yeah, we're not trying to capture that.
Yeah, thank you. Yeah, I think what you said also about the multiple sources would be a good answer to this, and like in interpersonal relationships using these concepts, because I think a big thing people do, which I find a bit absurd, is when we talk about inclusive language, they kind of just universalize it all of a sudden, and it's like, okay, we're just gonna not call anyone mothers, and everyone will be a partner, and everyone will just be a parent, and then of course it gets hit in the face with all the criticism regarding the cultural aspects of it. But I think in healthcare, like fascinating details and presentation, really. Thank you.
I like to say it aloud. I wrote it also in the chat. If people on YouTube wants to ask questions, just type it in and I will present the question to Matthew.
There was a comment, Susie, in the Zoom chat.
Yeah, there's a comment from Paula. I don't know if you read it, Matthew.
Yes, it's a very kind comment.
Just she laughed, so I wasn't in the process of typing a kind reply, but she flew away.
Yeah, I had the same issue as you, Nicole, when I was writing the book on phenomenology of pregnancy and early motherhood. It's it's hard. It's extremely hard, and I see what Daphne was saying. I mean, motherhood is such a heavy term. Yeah, my way to go around this was to present stories, and among the story there was one story of a same-sex couple who had a baby, and that was my way to say in the book, okay, here we are taking this term which is so gendered in a way that is as open as possible, but yeah, it's hard.
It's super hard.
And especially doing phenomenology, you might think, look, to make sense of like how one experiences the social role of motherhood, like is an important part of the phenomenology of certain people's pregnancies, right? That like if they think of themselves as a mum as they're going through pregnancy, and they read their experiences through that lens and through, you know, bullshit social structures that we live in, right? Like that's going to be an important part of their phenomenology. Similarly, like one of the like really kind of like fascinating things is that I've come across is sort of like trans men's experiences of fatherhood in pregnancy, right? Mm-hmm. And the experiences like trying to like make sense of like a certain form of masculinity through the process of giving birth, which is like very interesting, right? And like oftentimes there's a great feeling of tension, but also there's sometimes perhaps it's a problematic understanding of what masculinity is, but like there's an understanding of like there's a particular kind of strength in giving birth, and that kind of gets appeals to, and this buff resilience that you might think is like a way of like interpreting the process of birth through a kind of quite a particular kind of hegemonic masculinity as well. But yeah, it's fascinating, and I think especially with a topic like phenomenology, the best you can do is precisely what you did, which is go, hey, these are these particular kinds of experiences and the way they frame them, and so on and so forth.
Mm. Yeah, that's the only way actually. And yeah, when writing in Italian, for instance, in Italy there's a huge debate because trans feminists try to use the expression, which is not perfect, but that's what we have in Italian, people with womb, with uterus, for describing biological female people who actually may eventually give birth. But there's a huge crusade against that, because plenty of feminists, also in academics here, repeat that, giving birth is a feminine privilege. this mystique around pregnancy and reproduction is very much strong in Mediterranean area. Of course, it has some cultural dynamics, but that's a lot to handle, especially in our, I mean, I think much more than in Anglophone area in the US and in the UK.
Yeah, it's a fascinating kind of feminism, and I would love to see how it got to Italy, because I associate it with a particular kind of strand of, especially American kind of cultural feminism. And I associate Italian feminists with a bunch of like Marxists, and so I would love to know the story of like how it came to Italy. And so that's fascinating. I'd love to know more about the history of Italian feminism. It's my real response to that, I think.
No, it's just another reflection to bring on the table, because for some people, you know, erasing, which is not on, you really do not erase, you just make a theoretical clarification and a work of inclusion of transgender experience into reproductive practice is lived as I don't know, a way to dispossess women from this. So there's also this other layer of complexity, especially lived experience, because for some women, getting pregnant means being mother, and that's part of the identity they build up. So I can just stop here, but thank you, Matthew. That was fantastic. Plenty of things to, yeah.
Can I add something?
Yeah, I will.
Sorry.
Yeah, I will say this is something that we want to work on soon, which is this idea that like how we interpret these particular activities through a lens of masculinity and femininity and the identities that form around it. One example I think of is like, do we erase womanhood in referring to knitters as knitters rather than women who knit? And I think not. But there's like important about knitting as like an activity that women have done together and created particular kinds of bonds of solidarity around, which is like important to recognize. Like there's a particular kind of history of like suppression of women's crafts, like which needs to be recognized as a gendered kind of oppression. But nevertheless, it's not just women who knit, right? There are other people who knit as well. And so that like similarly for pregnancy, like how do we make sense of like the gendered oppression that takes place of women in reproductive contexts, whilst also recognizing that trans people are also often oppressed in these sorts of contexts as well, and are interpreting their experiences of giving birth as like an experience of fatherhood or an experience of like a parent, in a gender neutral sense, right? But we're still working on that paper. That's a difficult question.
Definitely, I saw that you have.
I was gonna add something to your erasure point regarding the word woman or mother. Listening to your presentation, I was also thinking like in Turkey and the Turkish language, it's like very unthinkable to even think of these linguistic considerations in the Turkish culture, for example, because like if I brought this up, maybe not in more academic circles, but outside of that, and that would be also like a very niche academic circle, I would say. Outside of that, if this was brought up, it would be like, oh, what do you think about like trans man? It's like trans women are still man and they can't give birth, like, and trans people can't even still, I think, exist in life as like normally perceived dignified individuals. So like including this language or these linguistic adjustments don't really have a lot of functional value also, I think, because their womanhood still is something that has to be recognized even. And I think in the West it has been, and now it's like okay, we recognize that also like women at the same level as men, so now it's like, okay, let's go one level above and include everyone, right? So I think this adds to your point in a sense, because it's so like loaded also in different cultures, how we have to maybe fight for these groups and identities still. So it would be so interesting to do like a transcultural comparative study linguistically like this in healthcare even, I think.
Yeah, and totally. I it's something that, like, if I knew more languages, I'd love to do. Unfortunately, I'm one of those sort of like parochial monolingual English people, so I'm ill-equipped to do it. But I know that people like Martina, for instance, are going to do the more interesting work that you suggest. And absolutely, I think the material conditions that sort of lie behind, or sort of which are preconditions for like this being a useful project at all, you know, they need to be met in the first place, right? Like, if you have a country where being trans is illegal entirely, this sort of project sort of never gets off the ground in the first place. Like, there's other stuff that needs to be done for the liberation of women and trans people before you can even get to this sort of stuff. So in a way, it's kind of a first world problem, but also it's like a problem, you know. So it's one that needs to be solved, as it were.
So thank you for this wonderful conversation, for this presentation. It's incredibly helpful for us present and us as a society. I mean, trying to make space. And so we can watch the video on YouTube. Probably there will be more questions showing up later. And thank you, Matthew, and I mean, and your colleagues who work on this presentation. So see you next Friday with another webinar, Transforming Perinatal Mental Health Provision in the Workplace, with Wilkinson, Lenny and Dadin from Open University. So thank you so much for being here.